Welcome, welcome, welcome in everyone to Care Patrol, Care Concierge. It's Monday, our new day, and last Friday was another new day for us. We hope, I'm a little concerned that our new times have not been picked up by some folks as our attendance is a little down, but I'm happy you're here. Thank you for making the investment in yourself and in your career to seek out and take part in continuing education. Today we are discussing Parkinson's and quality of life. This was an article I encountered recently and found it very informative in a general sense. Now, those of you who work with Parkinson's patients may find this a little sophomoric, but I hope those of you who don't spend a lot of time with folks who have that ailment will gain something today. You may know that Care Patrol is a referral and placement service. And what that means is that we get referrals from folks like you who we then meet personally and understand their activity of daily living needs by observation and question. And then matching that information along with their budget or geographical preference or other factors, we then refer providers to them of various health services. If the provider's private pay, and if they use the provider pays Care Patrol. And if they don't, then Care Patrol is unpaid. We never invoice families. We're always free to them. So I hope that makes you feel more comfortable in referring us, knowing that there's no expense to the referral for your client. So today, again, it's Care Concierge. It's Parkinson's and quality of life. We are Care Patrol, and it's quite our honor to be able to present these CEUs to you every week. And I so much appreciate those of you who attend regularly. I hope you are getting something from it. Let's get through some housekeeping as we continue to allow people in. And let me just say this first and foremost about the screen that you're seeing. Those of you who are seeing a screen, it's not a full screen. It's the PowerPoint, with the slides to the side. And the reason is that my computer died, or I thought it died. It turns out it was just a screen, but I'm using a television and a detachable hard drive to do this teaching today. And so for whatever reason, I can't get Zoom to perform in the way that I would like, which is not unusual for me. But anyway, I wanted to apologize. I know it's distracting for you, but I wanted you to know why, and also just give my apologies. You may know that your computer and or phone are muted. However, we will have opportunities for discussion. And if you want me to turn on your mic, just let me know in the chat room. If you're not familiar with the chat room, you should be able to slide your mouse around your screen, either to the top or to the bottom, and then a little pop down will come down and you'll see the word chat as one of your options. Click on that and share information with us if you will. And just know that your phones are muted. So do ask if you'd like to discuss something, and do use the chat room. I hope the chat room is a place that you feel comfortable, that this feels like a comfortable environment for you. I know so many of you on today's call and our other calls are regulars, it seems, or somewhat, and I appreciate that. But I'm hoping that this is a safe place for y'all, that you feel comfortable here sharing with other people things that are either professional or even personal to you. And I hope you'll use the chat room. We have an evaluation necessary for you to receive your certificate or your award of 1 hour. And that evaluation is due at 8. I have moved the time back for some folks who were struggling. And I know that invariably it seems like at 10 till 5 every day, some problem walks through the door. So I know that, cutting them off earlier in the day doesn't help some of you. And that's the goal here, is to make this easy, not hard. It is password protected, the evaluation. And so listen for the password. We give it out about 12:45, 12:50. And oftentimes folks on the call are kind enough to remember to mention to me in the chat room that I need to give it. So we'll give the password out later today. And we do that in order to make sure that the Alabama Board of Nursing, who credentials us, and the Alabama Board of Social Work Examiners who credential us that we can prove to them that this was a live and not a recorded CEU because of the use of the password. So you have to, theoretically sit through the presentation to hear the password, to do the evaluation and be credited for a live hour. And as y'all know, you have to have, so many live hours, and then you can have so many recorded. But we give paper certificates to everyone at the conclusion of the evaluation period. And then for nurses, we upload nursing hours to the ABN. Now, about that for you nurses, I am technologically challenged, which is a nice way of saying I'm incompetent with computers. And so I cannot get the ABN software to load. Tried everything I know thus far. Still working on it. We'll get it done. Just haven't done it yet. I want to apologize to you all. I know some of you may need to renew, and I'm sorry to be holding you up. But we will get it loaded, and we will at that point upload all nursing hours dating back to when I started doing this in February. So we do appreciate you being here. We do have a participation code word that unlocks the evaluation. The evaluation is necessary for you to get your certificate. And those of you on the phone or not seeing the screen where the Survey Monkey address is posted, I'm going to read it now for those of you to take note of it, either in your phone or on a pad or however. The Survey Monkey evaluation tool can be reached or found at this link, https:// www.surveymonkey.com/r/all uppercase letters, T as in Tom, N as in Nancy, 3, J, L, 8, L. And so one more time, if you weren't able to get a hold of some mechanism to make a note, I'll read it again. It's https://www.surveymonkey.com/r/all uppercase letters, T as in Tom, N as in Nancy, the number 3, J, L, the number 8, L. And remember, it is password protected, and the password is case sensitive. And so again, those of you who've just gotten in, welcome to Care Concierge with Care Patrol. We take place most Mondays and Fridays at noon to allow you all to receive live certificates or awards of 1 hour. And we appreciate all that you do, and particularly investing in your professional lives by seeking continuing education, not only with us, but I'm sure with others. So let's get started. We have 3 objectives, and you're going to be asked about these on the evaluation, so do make note of them. And please do be candid when you evaluate us. I'd love to know where we can make improvements and where we meet the goal that we set for ourselves and when we fall short. I'll tell you one thing my wife pointed out to me is that I tend to move my head a lot when I talk. I didn't know this. And she says, she's a veteran of Zoom calls, that it's distracting. So, so I don't mind having that sort of criticism, because I don't think criticism is a loaded word. It's a neutral word, and it's just the attempt to get better. So do be honest when you do the objectives in the evaluation. Our objectives are 3. The first is to name the 4 cardinal symptoms of Parkinson's disease. Our second objective today is to list the 4 pillars of proper sleep hygiene. And I'm hoping for a good discussion there. And then we're going to name a type of exercise, and a diet plan for Parkinson's disease. And really, when you're asked about this and the objectives, just, ask yourself, can I name this or not? I don't have a drop down to say, what are they? So don't feel like you're going to have to make notes. Just know whether you can, I meet these or not. Parkinson's disease. This was an article I found, and I really enjoyed it. And as I said earlier, for those of you who heard, I believe that this may be a fairly introductory level piece of information for some of you that will be helpful. For others who work with Parkinson's, this may be a bit of a yawn, but I appreciate you being here. And I want to thank Diana Tootin for posting, if you haven't seen in the chat room, the address to Survey Monkey. So thank you, Diana. That's very kind of you. I appreciate that. Parkinson's onset typically happens between age 55 and 65. So having just turned 55, I'm in the sweet spot, so to speak. And I found out recently that my cousin, who's 7 years older than me, was diagnosed with Parkinson's last year. And so this is a topic that's near to me, with him. And unfortunately, the prevalence, if you have the predilection of the genetic makeup to lend yourself to Parkinson's, you may not get it at 55 or 65, but the prevalence increases as you age. Then the symptoms can be subtle, and this is what's so difficult about diagnosing Parkinson's. And the symptoms are not only ignored by the patients, but even by spouses who are with them each day. And these symptoms include a tremor at rest. This seems like something that we all can kind of identify. That's my sense of Parkinson's, is that someone would have tremors. Slower movements and a lack of arm swing. Now, I was thinking about this, and I bet I could watch every one of y'all. There's 77 of y'all. Every one of y'all walk across the room, and I would not know if you had a lack of arm swing. So, I mean, that's so nuanced, don't you think? Gait and posture changes, that to me would be more evident, more obvious. You know that people who have Parkinson's tend to stoop, they tend to bend at the neck, they tend to be slower moving, as we said earlier, and tend to either take small steps or even shuffle. And this is the thing, that the voice softens. And again, this would be something that to me would seem subtle. Would you notice that quite? Because it would be over a period of time. And with my cousin who was diagnosed, he has a soft voice anyway. So I think that would be doubly difficult to ascertain. And then, what we do see, if we were having tremors or lack of gait, arm swing, or difficulty walking, we know that these symptoms would either be on the left or right side. It predominantly would affect one side, not only, but predominantly affect one side. And Parkinsonism is chronic. It's a neurological disorder, and you progressively lose your motor function, and resulting from the degeneration of neurons in the area of your brain which control movement. PD, or Parkinson's disease, is the most common form of Parkinsonism, but about 15% of folks who have Parkinson's have atypical Parkinsonism. So again, think about the difficulties diagnosing. The reason that what causes Parkinson's is a lack of dopamine. And it results in these 4 cardinal symptoms that we are naming for you and that you will be evaluated on, remember. These are 4 cardinal symptoms: tremors, muscle rigidity, slow movements, and difficulty walking. And so generally in the early stages, and again, this complicates diagnosis, only 1 or 2 of these 4 cardinal symptoms may be present. And those that are the most defining is the slower movements, which is, as you all who are clinicians probably know, bradykinesia. About 30% of all patients never develop a tremor. And so I mentioned earlier, this was my sense of, Parkinson's. To me, I just think of that as being someone with tremors, and yet 30% of Parkinson's patients never develop a tremor. But they do have muscle rigidity, and they do have changes in gait and balance. So there are, in addition, to the four cardinal symptoms, motor and non-motor symptoms that we can associate with Parkinson's disease. And the motor findings or motor issues would include a lack of arm swing, which we discussed, a change in facial expression. Yes, ma'am, Miss Thomas, I'm sorry, excuse me, y'all. Miss Thomas, she says she's licensed in the state of Georgia. Will these transfer? If you're a nurse, I can reach out to the Board of Nursing. If you're or you can load your own, presumably. You may know, you may not know. So this will be news to all of you, but generally nursing CEUs are reciprocal among states. I don't think this is true for New York State. And there may be another state out west, and maybe two others, but for the most part, most states, allow reciprocal hours. So you can be in Georgia or New York, well, not New York, Montana or, Chicago, wherever you are. If you get a CEU from someone in Alabama, it should process in your state. So if Ms. Thomas, it may be that you need to ask the ABN, but I'll send you the certificate and let's find out. And if you don't, if you have difficulty, let me know and I'll work on it for you. Excuse me, y'all. That was a good question from her and I wanted to answer it. So lack of arms, change in facial expression, muscle cramps in the feet or toes, and how annoying would this be, y'all? There's nothing worse than cramping to me, especially in your feet. And then shuffling gait and small steps, which, either or is sort of what we see. Non-motor symptoms would include depression. And I mean, who wouldn't be depressed? Knowing that you have this chronic disease for which you don't know how it will progress. And of course, you might assume the worst in the beginning. And so depression and anxiety, depression and anxiety are playmates. So generally, if you have depression, you have anxiety. If you have anxiety, you have depression. So that's no great revelation that one would have depression and anxiety in terms of their non-motor effects of Parkinson's disease. It does affect sleep. We'll talk at length about this. And it does cause memory loss. And so it is a form of dementia. It's not one of the leading forms, but it is a form of dementia that affects a number of people. And then there will be behavioral changes that occur with Parkinson's as someone progresses in their disease. Gail, thank you, Gail. Gail answered this for us. Thank you, Gail. You're so kind. You always comment, and I appreciate you. So here we see the prevalence per 100,000 folk in US and how the prevalence of Parkinson's among that age bracket, you can see it grow into the 80s and 89. And the only reason I would think it, if you live to 90, you probably don't have chronic issues or not as much, or you just developed them late in life. And so here's another table. It may be something you can cut and paste or take a photo of, but these are possible symptoms of Parkinson's, as we've sort of discussed, but we'll go deeper. So the motor symptoms are a resting tremor. I think you all can appreciate what that would be. Rigidity, bradykinesia, muscle cramps. And then there's dystonic posturing and hoarse or soft voice, asymmetric decreased arm swing, and drooling or excessive saliva. Now this, to me, would cause depression. If I were uncontrollably drooling, I mean, that would be a hard emotional thing to endure. Spiritually, it'd be difficult. With non-motor symptoms, fatigue, we'll talk about this, reduced energy, and of course, this could mean any number of things. Seeing for someone who exhibits fatigue and reduced energy, you wouldn't immediately go to Parkinson's. There's so many diseases that it may be. You might think thyroid, you might think anything. Sleep disturbances, we'll discuss these at length, as I said, constipation and urinary frequency. And I would think again, in terms of nuance, men as they age, generally urinate more frequently. So this would be hard to sort of say, well, is this aging or is this something else? A decreased sense of smell. And I think that would be most noticeable, frankly. Orthostatic hypotension, I'm sure you know, but with people on standing, their blood pressure drops and they faint or fall. And again, that's something that could be any disease process. You wouldn't necessarily think Parkinson's, although people with Parkinson's exhibit these symptoms, memory loss and a change in speech and swallowing. And so I want to ask, and those of you who are new today, and those of you who are here Friday, remember that one of the criticisms, and I asked y'all earlier for criticisms, one of the criticisms we received in a recent survey it wasn't really a criticism. It was a statement that the person missed live in-person classes, and what she missed was the interaction of them. And so I was thinking about this, and I thought, you know what, let's try and make this a little more interactive for y'all. So it's not just me talking and you passively listening, but get involved, get engaged. So if you are concerned about yourself or someone else who might be showing signs of Parkinsonism or Parkinson's disease, typical, please identify, but don't identify them, okay? But just say, yeah, me, and we'll just, each of us on this call, just send a little prayer to you. But if you have a worry, if you have a concern, let us know. We're a group here to help one another. And that's what I want you to understand. Each of you are servants. You serve the population that come to you. And each of you then are alike in that way. And so I want this to be a place where you can come and be regenerated, refreshed, renewed, and also take care of yourself. And so I say this to say that I want this chat room and these talks to be something that is very comfortable and easy for you. So clearly this question doesn't ring true with anyone. So it may be that all of you here today are novice to Parkinson's, and I'm sort of glad of that because I feel better about the information we're presenting. So diagnosing Parkinson's requires a clinical diagnosis, clearly. And it's based on a detailed history and neurological examination. That makes sense. Are y'all having trouble hearing me? I got a note on my television, which is now my computer, that my internet connection was unstable. So if it is, let me know. The initial workup, yes, Amy, you say yes. I don't really know how to fix that. Let's see. Okay. Well, I'm sorry, and I'm sorry to interrupt y'all. So the initial workup usually contains a CT or MRI and can mimic normal pressure hydrocephalus and tremor or gait disorder resulting from stroke. So again, nuanced diagnosis. There is a newer imaging modality, and it's called, and I've looked for the pronunciation of this, so those of you that know this, please correct me, but as I can figure it out, you would call this a DA-T scan or a DAY-T scan. And it estimates dopamine transporter levels. So this is the surest and easiest way to determine if there are dopamine producing cells and dopamine transporter levels, and therefore the absence would indicate Parkinson's. But, again, being the best response that we've noticed of those who've been diagnosed recently is levodopa treatment in a therapeutic trial. It converts that drug, and I hope, again, I've pronounced it correctly, that drug converts in the brain to dopamine. So it makes up for some of the loss that's occurring physiologically. So let's be clear. Yeah, I think someone is unmuted. Let's see. Let's be clear that Danielle Goodson, you're unmuted. Would you mind connecting or muting? So anyway, the premise behind treatment in Parkinson's disease is symptomatic relief, and symptomatic relief that enhances the patient's quality of life. There are no drugs yet discovered that definitively show that the drug slows the disease progression of Parkinson's. But levodopa is the gold standard in treating it today. And then there are a host of adjunct medications used in the treatment. Dopamine agonist. So again, like levodopa, where you increase the level of dopamine production. The inhibitors, the anticholinergics, and glutamate antagonists. So you nurses will identify with this immediately, and the rest of us will catch on. As the disease, I think did I skip one? No. As the disease progresses, clearly we're going to have to reassess, adjust, and change our regimen of medications and treatment plan, under, we hope, the close supervision of a movement disorder specialist, which would, be a physical therapist or occupational therapist, I'm assuming, or a neurologist and a neurologist. And you would want one clearly experienced in your disease. Now, really, the best we can do is to take a holistic approach and use the levodopa or other adjunct drugs. But we need to make some real lifestyle changes. And how often do we hear this? I mean, I feel like in every talk that we give, just about, and certainly last week we talked about caregivers, we talked about the need for lifestyle changes: diet, exercise, sleep. These are the things we always hear. And doesn't that ring true? If we hear this about Parkinson's and about stress, and this is something we need to take to heart, y'all. Again, I'm telling you to take care of yourselves and include lifestyle changes like diet and exercise. And then, if you were to be a Parkinson's patient, you want to pay attention to your autonomic symptoms like blood pressure fluctuations or urinary frequency and sleep disorder. So we have to have a plan then, in a sense, to address those, to optimize our quality of life. And Gail, I'm going to read Gail Thrasher's comment, and y'all will see how much I enjoy talking with people, because I'm always going to probably interrupt. And if that bothers you, I do apologize. But Gail says, my relative with dementia was finally diagnosed with vascular dementia. And we talked about this, didn't we, Gail, that vascular and Parkinson's are very similar. She had tremors at times, and they considered the possibility of Parkinson's, but finally said that her tremors were a side effect of Zyprexa. Isn't that interesting? And we've talked about drugs in the elderly, and the more that we drug the elderly, the more that we're likely to see, adverse effects like these tremors. So, Gail, that's a difficult diagnosis, and I feel for you and for your relative, but in many respects, I'm very happy they don't have Parkinson's. And so, with the regimen of medication and lifestyle, we can manage Parkinson's disease for many years, and you see that people with Parkinson's may go 20 years with and be relatively well off. Sleep, we said earlier, we would talk in depth about. Sleep is one of the greater issues with Parkinson's patients. And we know that sleep, enhances our physical well-being. And so it's clear to think that if we had a chronic disease and we were lacking sleep, that we would be in worse shape. And sleep, comes naturally to some. Like I could fall asleep right now, quite honestly. I sleep that easily. And others don't. But what we want to work toward for Parkinson's and for general quality of life is a non-fragmented, restful night of sleep that includes REM, dreaming. And many factors can disrupt healthy sleep. We know this to be true. Chronic disease being the one we're discussing today, or insomnia. So many people, it seems, have, and I can't imagine how terrible that must be. And then insomnia or chronic disease makes someone either have an inability to initiate sleep or to resume sleep if they wake up, or to maintain sleep for a reasonable amount of time. And so we'll get into those. And if you're sleeping with Parkinson's disease, sleep disorders are common, and both early stages of the disease and advanced stages of the disease. And Parkinson's disease folk will have an REM, sleep behavior disorder, or RBD, where, and we talked about this, I think in February, but this is when someone acts out their dreams in their sleep. So if they're running in their dream, they might be running in bed. Or they might lash out in bed. And so this would be one of those things I think that you would notice. But I know, we all know that lack of sleep makes the next day harder. And you can imagine then, if you have a chronic disease with some motor and cognitive issues maybe present, how a lack of sleep could exacerbate those. And here's the thing, people with Parkinson's, one of the reasons that they tend not to sleep as well at night is because they tend to sleep during the day in the form of naps. And the reason they do this is because of just the sheer exhaustion of having rigidity or tremors, on and off cramps. It would just be emotionally and mentally draining, physically draining for the person who naturally would go to sleep, during the day. And part of this would be the quote wearing off of the Parkinson's disease medications, which would also cause an even enhanced and greater fatigue within the person. And so we then treat this off phenomenon in order to stimulate rapid eye movement sleep behaviors that we know from studies show that we are sleeping and achieving a quality night's sleep when we're having rapid eye movement sleep. And so while it would appear that if your partner were thrashing in bed or not sleeping or up at night, you would think, well, okay, there's something amiss. Not necessarily. It's the most well-known of all of the sleep, of all of the, Parkinson's disease issues. Sleep is the most well-known, but it's often overlooked by those who are seeking to diagnose. Evaluation is paramount to determining whether this sleep disturbance is somehow associated with Parkinson's, or if it's some other disorder like sleep apnea, for example, or medications, which would be, in a sense, sort of back to Gail's story that her relative had tremors, which they thought were Parkinson's, and yet they weren't. They were an adverse reaction to a drug she was taking. So at baseline, we know that sleep hygiene is important, maybe most important. And so sleep hygiene is what we want to engage in. And this promotes sleep, and it avoids or removes these negatives from us that prohibit us from getting or staying asleep. And so the approach that we'll take to proper sleep hygiene, we can summarize into 4 pillars. This is one of your objective questions. The 4 pillars of proper sleep hygiene are: 1, establishing a routine; 2, setting the mood; 3, understanding the importance of timing. Think about that. And avoiding unfavorable actions. So let's get into it. Well, first, let's ask this. What do you do when you can't sleep? What works? Please share in the chat room, or if you want to talk, let me know. Shoot me a direct message or a general message to unmic you, and I will. So does anyone have any go-to things that they do when they cannot sleep? Melatonin has an adverse effect on Parkinson's, so that wouldn't work. But you don't have Parkinson's, neither do I. Jennifer reads, Sarah reads, melatonin. I do find that reading puts me right out. But I think reading is good. It's something I share with my kids and I'll share with y'all when they can't sleep. It's sort of almost like the meditative practices that Stacy meditates and her husband, a sound machine, deep breathing. Okay, I'm about to get into that. So this is what I tell my kids: lay comfortably and breathe normally. And then as you're breathing, try and relax your toes. Just really focus on your toes and see if you can relax them. Don't strain, don't stress. Just feel your toes relax as you breathe in and out naturally. And then as you feel your toes relax, then move up. Feel the tops of your feet, your arches relax, and breathe normally in and out. And then move to your ankles. And again, don't stress, don't strain. Just feel your ankles relax into the mattress. Keep breathing. Move up to your knee, move up to your hip, into your diaphragm, your fingers, all the way to your head. And if you're still awake by that point, well, maybe read a book. But that has always worked for me, and it works for my children, and hopefully it'll work for you. So sleeping with Parkinson's disease, pillar number one, and thank y'all. Oh, I didn't thank y'all. I do want to thank y'all for commenting. I love that. And we had so many good comments, mindless YouTube videos. Some folks watch TV. One of you prays at night, and I love praying at night if I can't sleep. A lot of you read. I think, Deborah, you mean watch TV or read. I don't think you mean feed, although that would be what I might do. I might feed. Debbie prays for people on her prayer list. So I tell you, Debbie, add people with Parkinson's, if you will, and I will too. So establish a routine. So, and this is, you know what this is, routine. It is, and in setting your routine, let your internal clock guide that routine. So in other words, don't think you have to go to bed at 9 if you normally go to bed at 10:30. Go to bed at 10:30, but make sure this is an appropriate. Don't go to bed at 2:30 in the morning. And your routine is what you would expect. It's all the things that you and I do. But what that does for the brain, if we'll do it every night instead of sleeping on the couch and then going to bed and trying to go back to sleep, if we'll follow our routine of putting on our pajamas, brushing our teeth, turning down the sheets, climbing in, propping up the pillows, grabbing our book, whatever that might be, that's going to signal to the brain that sleep is near. And, generally we say that if we can sort of tailor our lives to the sun versus otherwise, that's a more restful sleep than by starting it late at night. Now, it's so interesting. I have so many patients or clients really who are all elderly, but many of them stay up all hours of the night and then sleep all day. And it doesn't seem healthy for them. Of course, it's not my place, but it does worry me. Set the mood. We know about setting the mood. And it goes to this. The bedroom should be used for two reasons. Sleeping, and if you have a partner, intimacy. And setting the mood for either is key. You know this. Proper sleeping includes a dark, cool, free room. Now, how many of you, I wonder, and this is not a question I put in the presentation, but do any of you use those dark out, block out curtains? My son does. He likes to be in a cave. Oh, Maison, Sarah, you do. Joanna, yeah. Y'all are blackout curtain people. Stacy uses a sleep mask. How does that work, Stacy? Does it not bother you? I've seen people do it. And I just feel like it would make my face itch or something. Stacy, you found a comfy one. Okay. So yeah, blackout curtains, and removing distracting devices. Now, some of you said, and this concerns me, that you watch TV in your bedroom. We'll talk about that in a minute, but there's some other things that you might do with besides blackout curtains is, and I think one of you did say she burns a candle or puts a scent in the air. And my wife has found these things, I think they're called Scentsy, but you plug them into the wall and then they send you stuff in the mail and it really smells good, but you put the app on your phone and then turn it on. Like if you had, company coming over, you would turn it on, or you can set it on a regular basis to, just come off at the same time. So that may be something in terms of setting a mood. If you're thinking, well, I want to get to bed at 10 every night and I want this, to set this ritual up, maybe turning on your scent at 10 is part of that ritual. And then there are people who will say stretching can assist. And I have done this. I've even tried in the past exercise. Now they generally recommend against exercise before sleep, but again, I can sleep pretty much anytime, and it did help me sleep. And then, deep breathing we discussed. And I think one or more of y'all said that you did meditation and relaxation exercises, which would involve deep breathing. And, the deep breathing does so much for us. If you're in a stressed position or have anxiety, some things at work, if you'll take 2 minutes and just breathe deeply and just feel the air go in your nostril and feel the air go as deep up your nasal passage and down your trachea as you can feel it, and then feel it going out, and focus on nothing but this. Whatever distractions occur, whatever thoughts occur in your mind, don't chase them, don't fight them, don't judge them, don't speak to them. Focus on the breathing. Feel the air go in your nose and out your nose, and just focus on that. And after a couple of minutes of that, you'll see that your blood pressure's down, your heart rate is down, you're calm, and you're better prepared to meet whatever challenging situation is in front of you. Now, timing, we've already said this, but we'll say it again. Living by the sun seems to make the most sense. It is our biological natural clock. So if we're doing things, like if we were to exercise before, bed, or if we had a meal that didn't sit with us, or we drank so much in the day that we might have trouble at night, we need to incorporate this into our, our preparation, if you will. So while exercise is important to all of us, and we keep stressing that, it's extremely important with folks who have Parkinson's disease. But for them, they need to do this in the earlier hours of the day and not the later, because it will inhibit their sleep ability. Now, again, if urinary frequency is an issue, then just simply reducing your fluid intake in the hours before nighttime would be helpful. And, this is true, again, for men, and men are largely the folks who have Parkinson's. So, this is a good topic for men in general. But now here's what I wanted to say to y'all that watch TV in bed, and I do too. So I'm not judging you, but it's not healthy for sleep. What it does, and it's not just someone's opinion that it's not healthy. It's actually a physiological fact. It's data that says that doing so, looking at any screen, whether it's the TV or the phone or your iPad, whatever it is, looking at any screen produces melatonin, or decreases melatonin, which is our body's natural way of sleeping. And some of you take melatonin, so you know that. But I just really want to encourage those of you, and myself and my wife who have trouble sleeping and uses a noise machine, that maybe we should not watch television in bed for her sake. And maybe you should try a night or two without it, pick up a book instead. I don't think I can get through 3 or 4 pages of a book. It might take me a dozen years to read a book if I'm reading it only at night. And in fact, that's true. I've been reading a book for 10 years, maybe more. And I'm still only halfway through it. But, gosh, I know it. That's, little bitty pieces. So I do want to encourage y'all, if you're using a screen, please consider using some other trick, noise machine, comforting scent, meditation, prayer, whatever it may be. But the screens are having a negative effect on you. And then pillar 4, we want to reduce or avoid, if we can, unfavorable things like clock watching. So what does that mean? And we all do this when we can't sleep. We keep glancing at the clock. Well, move the clock. It's very simple. If you're not sleeping, get the clock out of your room. Okay? Because what watching the clock does is to cause you further anxiety because, oh no, now it's 1:13 and I'm still not asleep. When am I going to go to sleep? And you get in this sort of drain. You just circle the drain of not sleeping. Similarly, if you're doing charting or something in bed and then trying to sleep, maybe try and do it at a different time of day, earlier in the day, because mentally stimulating things, again, affect our ability to sleep and stay asleep. And this is true again with us, you and I, just us daily. Avoid alcohol, avoid nicotine, avoid late night caffeine. And none of these will help you fall asleep. In fact, they'll have the opposite effect. I mean, they have the appearance of being relaxing, and you may think, well, I just need to relax and have a cup of coffee. That's going to dissipate. And then you're going to be left with not being able to sleep or frequently awakening. And there's now evidence that those who have Parkinson's disease, or anyone for that matter, all of us, there's an increased risk for us to have falls, confusion and dementia, or dependency on sleep aids on a consistent basis will be, a dependency with sleep disorder. So caffeine helps you go to sleep, dark room with music. Caffeine help. I don't know. I used to think I couldn't drink a Red Bull, which I'm drinking now, after 6, but I've disproven that. I could probably get a caffeine infusion and still sleep. And it says my internet connection is unstable again. I hope you're not having trouble. Physical exercise, we've said, is paramount to folks with Parkinson's. It's the major treatment, the single treatment option recommended, really, the single most important treatment option. And it enhances someone's ability to do the daily task, preserve their balance and mobility, and then improve their future by doing a consistent pattern of exercise. And it may be going to the gym, it may be stretching at home, but optimally it would be exercise with a physical therapist who can facilitate and exercise you safely, exercise muscle groups or movements or postures that will help correct any deficiencies that you may be having because of the disease state. We know this, therapists have that great ability to do that. And it's often uncanny, the things that they'll ask you to do. If you're getting therapy, they'll ask you to do a movement that you've never made in order to improve some issue that you have. And you're like, well, how could this have anything to do with anything? But lo and behold, it works. But with PD and exercise, our goal is consistency and safety, but consistency. So we have to be exercising on a regular basis. And research shows us that the variety and intensity of the exercise, when done with the physical therapist, can help delay issues with Parkinson's or potential limitations from coming to fruition. And this is what we would say to anyone. My cousin, who I mentioned, has a recent diagnosis of Parkinson's, is involved now in a UAB study in which he's getting very intense exercise. And he was saying he was going to be the Rock soon. So we'll see. But that's the kind of exercise that's needed. In other words, this is pretty physical and pretty intense. And you can imagine with motor limitations, it's even more so. So I'm going to ask you, what types of physical activity or exercise do you enjoy? And I'll tell you, for me, I currently do not exercise as much as I preach to y'all, and I do preach, and I appreciate y'all bearing with me while I do. I don't currently exercise other than walking my dogs, but I think that counts. You know, that's a mile. It's something, it's movement. But I do want to get into an exercise plan. And here's the thing. There are some ways to exercise. Oh, here, dancing, Stacy. I love that. I was about to say something about that. Pilates, stretching, running, changing side of the bed seasonally. That's interesting. Who said that? Deborah Lavender, changing sides of bed seasonally. That is great. My wife and I, whenever we would rearrange our bedroom, somehow would end up on opposite sides. But I'm going to suggest to her we switch sides just to see how that goes. Maybe that'll help her. My sisters are not local, but we three-way call and walk and talk 3 miles every day, every morning. That's great, Jennifer. One of my close friends, the only time you can reach her by phone, because she won't answer it, is if she's on a walk. And that, if you can, it's great because you got an hour to talk with her. Joanna, you run and walk and yoga. I think walking is great. Running, I'm probably too heavy to run. Amanda, you want to enjoy riding your bike more. Yeah. And my wife wants to bike, and I want to bike when it rains. I'd love to get wet in the puddles again. But the exercise that I've decided to, line dancing, that's great, Deborah. I'm about to say, y'all are ahead of me. So y'all may have heard, any of you in Birmingham may have heard of the Magic City Disco. Well, it is a group of people who are probably mostly my age, 50s, 40s, 60s, who do disco and perform at different things around town. And you have to audition to be in it. And my friend, a female friend of mine, longtime friend from elementary school, was able to get into this little group. And as I was talking about it to her, she said, well, they need men and you could just come and start right away. So I am going to be, I hope, if they allow me, and this is the big one, if they allow me, to be a member of the Magic City Disco. So I'm hoping to get exercise there. And I expect when I go to meet them on Thursday night that I will be able to dance about 30 seconds before I fall flat on the floor. But I bring it up to say this, the exercise doesn't have to mean gym. It can be anything in which you get your heart rate up for 45 minutes. Lori used to love dancing. So look up Magic City Disco. They just had their auditions. So they won't have them again until next spring. But what's fun about that group, I think, is that every time they get together, which is once a month, they dance together, for an hour. And I mean, what fun that's going to be. Even though I'm not a good dancer, I'll tell you that straight out. I have no rhythm, but I love dancing. Let's see if they take me. Cognitive changes. We see this in Parkinson's, but we do have hope because we see that there's a 60% chance of 60% chance after 15 years. So after 15 years of Parkinson's, there's a 60% chance you will develop dementia, but that's quite a while. If you were, diagnosed at 62, like my cousin, I mean, he'll be 87 or 77 if that occurs, and that's a ripe age, and he may not make that age, and it climbs precipitously after 20 years to 80%. And there's a difference in Parkinson's dementia or PDD and Alzheimer's dementia. And so Alzheimer's is the leading cause of dementia. It's about 85% of all dementias. Parkinson's is in the top 5, but it only affects about 5% of folks who have dementia, have Parkinson's disease dementia. And really, Parkinson's disease dementia is different from Alzheimer's in the area of executive function, which is, essentially the ability to abstractly think, plan, execute, and it also affects planning and attention, obviously, and concentration, all those executive functions. And it's consistent that those dysfunctions are consistent with the dopamine lack. Now, Alzheimer's disease is broader. So people who have Alzheimer's disease have a broader spectrum of issues possibly present. So theirs will deal with explicit memory issues, names, those sorts of things. A severe decline in self-care, the inability to recognize a family member, and the general disorientation. So they're quite different, but they're both dementia. And we've talked about dementias in the past in terms of, what we would do with those. Physical exercise, again, is the necessary supplement for Parkinson's. And it not only helps with the motor function, but helps reduce, it's been shown, data shows that high impact aerobic complex exercise done with a physical therapist reduces cognitive impairment in Parkinson's. This is a new study. And then cognitive exercises like learning new things or doing something stimulating or being social, or, all of those help as well. Now, having PD doesn't prevent you from exercising, and it doesn't eliminate the fact that there may be some concurrent medical condition that's affecting you in addition to the Parkinson's. And so we have to evaluate each symptom and understand, using your baseline and repeat memory screenings, if what we're seeing is related or not to your Parkinson's. So here's a diet plan for Parkinson's. Oh, and let me give you all, because it's about to end, the code word. The code word here, and again, we have a code word that allows you to get into the evaluation. You cannot open the evaluation without it. I'm typing the code word into the chat room. It is P as in Paul, D as in David, or P as in Parkinson's, D as in disease. And they're both capitalized, and it is, that does matter when you go to put the password in. It is case sensitive. So P, D is the password. In general, I'll hurry up, but it's the Mediterranean diet that is best for Parkinson's, which is unsaturated fats, loaded with antioxidants, no butter, for example, and it's good for all of us. So if y'all diet, we've got time, put in your favorite diet in the chat room, and otherwise we'll move right on to journaling. And here we are coming to the end. Basically, if you have Parkinson's, your body changes daily. Some days are better than others. And so because you only see your neurologist maybe once a month or once every 3 months, it's best, like with all chronic diseases or issues, to journal, and it not like your innermost thoughts, just, hey, I had difficulty with balance today, and I had eaten this, and I woke up at this time. Just maybe see if you can see a pattern. Weight Watchers is everybody's diet. And so we're going to now go to the close of this, because it's 1 o'clock essentially. The code word is PD as in Parkinson's disease. The survey evaluation is https://www.surveymonkey.com/r/ all caps, T as in Tom, N as in Nancy, 3JL8L. Thank you all so much for referring to us. Thank you for being here. Thank you for investing in yourself, and more importantly, in your clients and patients. We appreciate you. Your evaluation is due by 8 o'clock today. If you can't make it, no worries, shoot me a note. Here's my email, sbarnes@carepatrol.com, and I'll reopen the survey for you if you have any issues. Dixie Tyler, whose email is listed, works for us in Decatur and Huntsville, North Alabama. Jennifer Redding in Florence and Tennessee. Yvonne Eason in Montgomery and Auburn. And C.W. Merritt and I in Birmingham. So if you have referrals or have questions, please make note of our emails or call our 800 number above to ask us anything, not just a referral, but ask us to advise your client on something. We're free and we don't mind doing it. We're happy to do it. Let us know. Thank you all for being here. I will end us now. Oh, Stephanie, PD isn't working. Oh, it does work. Okay, great. Great. Okay. Got it. Okay. Thank you, Stephanie, for letting me know. So thank you all for being here. We'll see you Friday, I hope. So again, we're on Mondays and Fridays under a new title, Care Concierge with Care Patrol. I look forward to seeing you then. To register, you can either click the link in the email I send you with your certificate, or you can go to my website at carepatrol.com and select me as an advisor and see on my page a registration tool. Thank you so much. Have a great day. Have a great week. And hopefully we'll see you Friday. Well, this never does work as well as I would like. And then I'm left